Good morning. I want to talk about a very interesting procedure. We did a great one last week, and I realized I haven't shared any content on something called a direct submentoplasty or a direct neck lift. So this is a very unique procedure, and not all patients are going to be candidates for this. But what it basically means is that anyone who has a evident turkey neck appearance, a lot of excess skin that is drooping down almost into a fin-like structure. This is really going to be patients who are elderly, over the age of 60 or 65, patients who have had an exorbitant weight loss, and they are looking to get a focused, sort of shorter procedure that's going to address this potentially without the need for general anesthesia. And this is called a direct neck lift. Let me show you some examples. So here is a classic example of a patient who is a candidate for a direct submentoplasty. You could see that this gentleman has essentially a lot of accumulated skin. This isn't necessarily just skin. This is skin and muscle most likely. There's also going to be some disproportionate amounts of fat, whether it's in the center or along the sides. Again, some patients have had weight loss preceding this. And the patient really just has an isolated complaint. For example, it typically is more of a male population, hair-bearing skin, and they're just not able to wear a collared shirt or a high-cut crew neck because that skin is in the way. There's chafing, it's uncomfortable. And patients like this patient particularly did not complain about facial sagging, jowls, jawline, nothing, just this extra skin. Again, another patient, slightly less excessive skin. I mean, for the experienced eye, there's also other things going on. There's the visibility of the submandibular gland. There is also a chin descent here with missing soft tissue. There's a lot of signs of facial aging, but some patients are looking to get limited improvement in a focal area of their face and or neck. And this gentleman, again, just simply had a complaint that on the profile, the skin was in the way. It would bunch to the side upon wearing a higher cut, shirt. And it's just more of a, cosmetic concern, but also a little bit of an everyday lifestyle functional issue when that skin is just bunching and moving left and right. And that's really what they're looking to correct. So there's some things that are addressable with a direct neck lift, such as this profile appearance, and there's some things that are not, such as the entire jawline and jowl. So what exactly is done? Well, there's various techniques, but my go-to technique is in all direct submentoplasty. We have to directly remove what's here, that turkey neck appearance, by directly excising the redundant tissues down the center. This does lead to a healing and visible incision along the center of the neckline. The trade-off, of course, is that the neck fullness and excess is entirely and permanently removed, creating a smooth neck silhouette. In the correct patient population, patients who don't mind having this incision as a couple of week, month investment in healing in order to obtain a smoother neck, and that's really their only focus. It's an amazing procedure that can be done in the office, can be done under local anesthesia, or if preferred under light sedation anesthesia. The procedure takes about an hour and a half to do. So here's one example of my preferred technique and my geometric design. So this highlights the skin inside that polygon shape that will be removed. This is measured in sitting position. This is marked very accurately. There's specific measurements that I like to take. Once that skin is removed, that gives me access to the platysma muscle, which is the first superficial muscle of the entire neck. Oftentimes I will trim and tighten the platysma, same way as we do in a face and neck lift, except here I have direct access to it. In addition, I also have access to the deeper neck structures, such as the deep fat layer, which is under the platysma, as well as the deeper musculature that can create undesired contours in the side profile of the neck. There's also access to glandular tissue that can cause some fullness and circular shapes along the deeper jawline. So you have access to all of this, and of course, every patient's treatment plan will be unique. Okay, the next video I'm going to show cringe alert. So if anyone is a little squeamish or does not like to look at surgical footage, including muscular layers or deeper tissue layers, just buzz right through it. I'm sure there's going to be some sort of discretion or some sort of black screen first. However, I do want to show how open that access is. And of course, once the skin is removed and the patient's lying down, everything's kind of going backwards. So it looks like a much wider area that's open than it really is, plus all of the lidocaine that's injected, so it causes swelling and bellowing. However, the measurements are sacred, so whatever the measurements show, once we pinch that skin and mark it along the side, that's really all that's being removed. So here's that example of a video. There are platysmal muscles. They are sort of diverging towards the bottom of the patient's neck. You can see here that I'm running a suture through the muscle layer. That tightens the platysmal muscle and allows it to be slung up as much as possible. This patient did not require any deep neck work, so I did not go under the muscle to address the deeper fat and muscle layers as can be done. So really after this point, it's all about meticulous closure of the skin layer, putting those edges together. That actually takes the longest time in the surgery is to close the skin in order to maximize all healing opportunities that occur normally and biologically. Of course, every patient is counseled about scar management, incision management, laser skin resurfacing on this incision in the months to come. But the next step is going to be providing absolute meticulous closure to that skin. And here is the example of when the skin is approximated together. This is actually shy of the last layer of sutures that go along the skin. So there's a lot of things that's just kind of holding this geometrically together, and that is meticulous approximation of the deep tissues. You could see that the incision is not straight down. There is a zigzag along the center. This gives maximum camouflage. When the patient is sitting up, that first limb of the incision is really under the chin. So the only thing that's visible is really that little triangle and a downward extension. Occasionally I'll make 2 extensions along the heads of the sternocleidomastoid muscle here because it camouflages and sits better. There's also extra skin on both sides, so it can be carried a little bit lower. It really is just, again, a question of tailoring and meticulous attention to detail. So here's a before and after shown at about 4 months after surgery. You can see the improvement in the redundancy of the central neck. Again, these are isolated complaints. You also have to keep in mind that a lot of these patients have advanced medical conditions due to advanced age. There could be cardiopulmonary chronic conditions that are not cleared for the use of general anesthesia. And, traditionally we can address this with a traditional comprehensive deplane face and neck lift, but that would require multiple more hours under general anesthesia. In my hands, I like to use general anesthesia for surgeries like this. And that just predisposes the patient to a lot more dissection, a lot more risk of bleeding, and a lot more post-operative complications. So this is a nice alternative in the right patient, and case selection is so important in these cases. A view from the profile, you could see there is a significant improvement in the profile view, and here as well.